discuss IgE and IgE-mediated allergic disease. I know this is in 2 parts, but I'm just going to finish today because I'm on leave. So I don't want to have to be back here on Tuesday. Okay, but we'll cover the scope of everything that you need to cover, and then you'll go and do a bit more reading. So these are the learning objectives. By the end of this lecture, you should be able to outline the factors that predispose to allergy. And then you should be able to outline the mechanisms of early and late phases of allergy. And you should be able to outline the techniques used to identify allergens involved in immediate hypersensitivity. As you'll see, this is basically just the applied or the clinical aspects of the immediate hypersensitivity or type 1 hypersensitivity reactions. So what is allergy? Allergy was originally described as any altered reactivity to an exogenous antigen. And this would actually be more a hyperreactivity, exaggerated responses. But now, more often than not, it's been shown that people who have this type of reactivity tend to have like a genetic predisposition to that. So now it's synonymously used with atopy. So atopy is basically that predisposition to an immediate hypersensitivity reaction to environmental antigens, although this can also include food antigens, and it's mediated by IgE. This predisposition is a genetic predisposition. And I think we'll mention, what are some of these genes that may be involved in this predisposition. So I know I've indicated that environmental antigens, but it's not strictly just environmental antigens. If you remember, the sort of antigens that can cause hypersensitivity reactions are not limited to just environmental antigens. It could be any other innocuous antigen. That's why I'm mentioning even food antigens or things like latex and so forth, drugs. But generally, they tend to be harmless antigens, and the immune system responds to it in such a way that it's called exaggerated because that antigen wasn't going to cause much harm anyway. Okay, so atopy tends to run in families, and what I want you to note is that what people inherit is the atopy trait. So they inherit that, that susceptibility, but they don't inherit the allergy. So for example, you may have people in an atopic family. One is allergic to peanuts, one is allergic to pollen, one is allergic to cow milk. So it doesn't mean that if there's the people in an atopic family, they're all going to have the same allergy. Okay, so what they inherit is the trait, which is that genetic predisposition. There's also, aside from genetics, there's a role for environmental factors. And, just like every other risk factor you talk about in different diseases, risk factors for disease, you always have your genetic factors, you have your environmental factors, and then other influences. So the same thing applies to atopy. And this combined in several ways to skew the T helper responses into a T helper 2 type of response. Remember, the T helper 1 type of response is your usual pro-inflammatory response. It's the response we expect to predominate in the context of an immune response against an infectious pathogen, like bacteria, for example, or viruses. And this is the response that leads to production of pro-inflammatory cytokines by the T helper 1 cells. So things like your interferon gamma, your tumor necrosis factor. Now, the T helper 2 responses predominantly lead to antibody production, okay? And this is why we tend to get more IgE being produced. The type of antibody produced, of course, will be dictated by the cytokine milieu. So we know, for example, that if you get a response that leads to interleukin-4 and interleukin-5 production, then you tend to get your IgE preferably being produced. So in these people who have atopy, they tend now to have this imbalance where they have more of the T helper 2 type of responses than the T helper 1. Okay. So allergic reactions can be mediated in several ways, but most commonly, it's the type 1 hypersensitivity reactions that involve IgE production that cause allergic reactions. Okay, so you can have, for example, your contact allergy, which is a type 4 type of hypersensitivity reaction. Most of the allergic reactions that we'll see even in the clinical setting tend to be the type 1 hypersensitivity reactions. So in terms of manifestations, these are the major manifestations of allergy or your IgE-mediated disease: allergic rhinitis, asthma, atopic dermatitis or eczema, and food allergies. Okay. Of course, at the extreme, then you'll have your anaphylactic reactions. Okay. But you can also have non-IgE mediated anaphylactic reactions, which is not in our scope today. There's a phenomenon called the allergic match, which basically describes the process by which individuals develop different types of allergy at different times in their lives. This is usually noted in childhood, and it is seen in these people who come from atopic families. So, you know, in infancy, they present with atopic dermatitis or with eczema, and usually this more often than not starts to be noticed at weaning, you know, when you're now introducing different types of foods, and you'll later see in pediatrics how, you know, there's the guides to weaning such that you're not introducing everything at once, especially in the context of people who have atopy. And then, you know, as they grow older, they start now manifesting with different types of food allergies. And then later, especially when they start school, they start manifesting with allergic rhinitis and asthma that more often than not tend to be caused by environmental allergens, but food allergens can also cause or worsen the manifestations of allergic rhinitis and asthma. Okay. So that is basically the allergic match or the atopic match. Most of the time, because this, as I've said, is, you know, this manifests in early childhood and progress to later childhood. Most of the time, these allergies may improve spontaneously over time or just end. But what happens is that tolerance develops. If you remember the whole concept of tolerance, where now the immune response or the immune system actually, you know, just tolerates this antigens, which in this context are allergens. So they're able to recognize it, but not mount an immune response. So this is what happens a lot of the time in those that we see have resolution. Another thing that has been realized with urbanization is that the incidence of allergies is increasing or it's rising in the human population. This has been seen especially in the West, so in Europe and in the Americas. I guess we are also seeing it in sub-Saharan Africa, especially in urban regions. And there are a lot of theories as to why, you know, people are thinking, you know, we are not, you know, there's less and less exposure to germs. You know, if you remember, I don't know if you guys ever saw the time the Omo advertisements, you know, they kept saying that is good, you know, let your children play with that, you know, you can wash their clothes with Omo and they'll be clean. Probably alluded to some of that, yeah, it's good to expose children to germs so that, you know, you're challenging the immune system, because some people think, you know, there's a whole theory of the hygiene hypothesis where, you know, the children's immune systems are not being exposed to pathogens. So, you know, there's some sort of like inactivity. And this now helps to now reduce the T helper 1 types of responses that you would expect. And then you're getting more of the T helper 2. And then now they start responding abnormally to allergens. So yes, the incidence is rising. And so allergy is actually now, an important, or allergology, an important subspecialty in clinical immunology because of that. There's a lot of morbidity just because of allergies. Understanding the immune mechanisms behind this T helper 2 IgE mediated responses has led to new therapies. So there's also a lot of basic science type of research into these mechanisms, because this is what allows us, to know the details of the mechanisms of these processes, so that people can develop targeted therapies to either stop the process, induce tolerance, or just treat the manifestations of the diseases. Okay, so what are allergens? Allergens are basically the antigens that trigger an allergic reaction. So antigens that will trigger your T helper 2 IgE mediated immune responses are also called allergens. Remember, these immune responses are also triggered by parasites, especially your helminths. But in that context, they are not exaggerated as they are in the context of an allergy. Okay, so these allergens tend to be, as we mentioned, most of them are environmental allergens. So they tend to be present in the environment, either as small particles or as low molecular weight substances. If you think about things like pollen, things like dust, they're really small molecules, and they gain access into the host either after being inhaled, being ingested, or being injected. So, the environmental things like your dust or your pet dander, you're going to inhale those. Food allergens will be ingested. And then the molecules that would be injected, most of this will actually be drugs, okay? So the other thing to note is that they enter the host via mucosal tissues. So you see your respiratory tract majorly, and the oral and gastrointestinal mucosa, okay? Usually at very low concentrations, aside from food, okay? I mean, of course, we eat food in large quantities, but most of the time these allergens, especially the environmental ones, will gain access into the host at very low concentrations. And it's thought that that is one of the factors. If you remember your second year lecture on antigenicity and immunogenicity, the properties of antigens that will make them induce an immune response. Remember, one of the things was the dose. Another thing was the size, the molecular weight, okay? So if we're talking in that context of antigens and immunogens and inducing an immune response, you're actually, because we know the main function, of the immune system is to protect us against pathogens. So there you're talking of an inflammatory or a pro-inflammatory immune response. Now, so these allergens, first, they're small. They gain access into the host at low concentrations. So usually they should not induce a pro-inflammatory immune response. So it's thought that this is now, these are now some of the factors that now would explain why they will induce a T helper 2 instead of a T helper 1 type of response, okay? Okay, in terms of the chemical nature, they tend to be proteins or glycoproteins. So back to the characteristics of your antigens or immunogens, we said the best ones tend to be proteins and then the glycoproteins. Okay, so, as long as there's that protein component, if you have the polysaccharides on their own, they're not they can be good immunogens, but they're not the best. Okay, so allergens tend to be either proteins or glycoproteins, and they tend to have multiple antigenic sites or epitopes. This is important, maybe not for your scope, but it's important when it comes to testing maybe I'll mention it. If I forget to mention it, just remind me so that I can just explain what I'm alluding to. But if you remember the nature of an antigen, they tend to have more than one antigenic site, okay? So they have multiple epitopes. The other characteristic of these antigens that are allergenic is that they have intrinsic enzymatic activity, okay? So, for example, they can have some protease activity, and it's been shown that this enzymatic activity actually disrupts the integrity of these epithelial barriers at the mucosal surfaces through which these allergens gain access into the body. Okay, and now that allows them to get into the submucosa where they'll now interact with your antigen-presenting cells like your dendritic cells. Okay, they can also cleave and activate complement components at these mucosal surfaces. So this table just summarizes or lists a few. There are very many allergens, but lists a few of them. So for example, for the environmental ones, we have plant pollens, and they come from different types of plants like your ryegrass, ragweed, your birch trees. Also important when it comes to testing, if you're evaluating a patient for suspected allergy, the panel that you're going to test them against, especially if you're doing an in vitro test, should be relevant to the environment. Like if we don't have birch trees where that patient is coming from, we have no business now testing them for serum allergen-specific IgE to birch tree, okay? Okay, foods, so nuts, seafood, eggs, peas, beans, milk, also important. If you're suspecting a patient has allergy to a food, you're not gonna test them with a panel that has food allergens that they don't eat, okay? So for example, especially out of the urban areas, many Kenyans don't eat seafood. So it wouldn't make sense to now test them with a panel that has seafood. You don't expect them to have been exposed to that, okay? So you have your drugs, insect products like your bee and wasp venoms, the cockroach calyx. This would be an indoor environmental allergen, and your dust mites. Dust mites are very common allergens. That's the Pteronoceous group of allergens. Mold spores, so molds are also very important. Pet dander, latex, foreign serum. So foreign serum can cause both a type 1 and a type 3 hypersensitivity reaction. And then vaccine, so to be a component of that vaccine, okay? Sometimes it may not even be the antigen in the vaccine. It could be, the other additives that they add that would be responsible for causing the allergy. Maybe we'll, when you have the lecture on vaccines, I think they should mention what do they add in the vaccine, or what are the constituents of a vaccine. Okay. So we said that these reactions are mediated by IgE. So, and I said that the isotype of immunoglobulin that will be produced by your B cells will be guided by the cytokines that are stimulating these cells. So usually interleukin-4 is the one that will co-stimulate these B cells to secrete IgE, okay? The other thing we've mentioned, or rather something we mentioned about IgE in second year, is that the Fc portion of IgE has a very high affinity for its receptor, its Fc receptor, which is called an Fc epsilon receptor that is expressed on tissue mast cells and eosinophils. Basophils also express them. So this is different from the Fc gamma receptor, which by now you can see that the Fc gamma receptor should be for IgG. Fc gamma receptor is expressed by your phagocytes and your natural killer cells, and these are the ones that would mediate, opsonization or antibody-dependent cellular cytotoxicity. So the Fc epsilon receptor, there are two types. There's the Fc epsilon receptor 1 and epsilon receptor 2. The epsilon receptor 2 is more involved in regulation. Okay, so it would downregulate these hypersensitivity responses if IgE binds to it. So usually in a type 1 hypersensitivity response, IgE binds to the Fc epsilon receptor 1. That is the one it has high affinity for. So it's called the high affinity receptor. The receptor 2 is the low affinity. Okay, so that means when we have secretion of IgE by the T helper 2 cells, of course, this is happening in serum. Preferentially, this IgE will go and bind to its receptor on the tissue mast cells and basophils and serum. So on tissue mast cells and eosinophils. Remember, basophils are in blood, but at very low concentration. Okay. And I mentioned that IgE is usually generated in response to parasitic infections, majorly the helminths, but allergens can also trigger IgE production. Okay. Now, so because atopic individuals are predisposed to producing IgE, they may have elevated total IgE levels. So if you, if you took the serum and you wanted to test for the level of total IgE, it may be high, but it doesn't always have to be high because of that high affinity. Okay, so you may get that they have atopic individual doesn't have a high total IgE level in their blood, but their mast cells and their eosinophils are saturated with the IgE because of that high affinity. Why I'm highlighting this is because a lot of people think one of the ways to screen an atopic individual would be the total IgE, but it may give you a false negative result by giving you a low result. So it's not, like ideally it should not be used to screen for atopy, okay? And that total IgE includes all the IgE in the serum. So the IgE that is there, that is specific for different types of helminths, especially in our setting, we're in an endemic area for parasitic infections. So a lot of the IgE we may have in our patients may actually be specific to helminths. It may not be the allergen specific IgE, okay? Okay, the cellular mediators, if you remember your type 1 hypersensitivity reactions, the cells that contain the inflammatory mediators that are responsible for the allergic symptoms are your mast cells, your eosinophils, and your basophils. And these are the cells that express the high affinity Fc epsilon receptor 1. Epsilon receptor 1. Actually, yeah, so sorry. The epsilon receptor 2 is expressed on B cells, okay? Majorly, not on your mast cells and your basophils. Okay. So when the IgE binds to this receptor, it activates these cells, but this only occurs, this only occurs when there's cross-linking. That means you have your allergen, sorry, not when the IgE is bound. When your allergen binds to the IgE that is bound to your cell, it activates the cells and causes them to degranulate. But this only occurs in the context of cross-linking. So this means you have two IgE molecules, two separate IgE molecules onto which your antigen has bind. So your antigen or your allergen binds to the FAB portions of two different IgE molecules. That is what we call cross-linking. And that is what will now activate the cell and cause them to release the contents of their granules, okay? Now, the other scenarios where you can get degranulation of these cells, for example, C5a of complement, remember we call it an anaphylatoxin. C5a can bind to a receptor, its receptor on these cells and cause them to degranulate, okay? That would not be an immediate hypersensitivity reaction because you're not having IgE involved, okay? This can also occur when there's, a sort of, what do I want to call this response? It's a sort of urticarial response where you have signals transmitted by the nervous system in response to different things. For example, change in temperature. Okay, you can get degranulation of your muscles. Okay, so it could be change in temperature. It could be physical contacts. So all the triggers in the realm of your urticarial sort of reactions, which is out of our scope for this lecture. Okay. So the other important cell we've mentioned is the T helper 2 cell. And we talked about the fact that patients with atopy have a skew in terms of their T helper responses. They have more of the T helper 2 than the T helper 1. You know, once you get activation of your CD4 positive T cell, once it recognizes the allergen, I guess the characteristics of the antigen are the ones that will determine what transcription factor will be, or what gene will be activated in this cell so that it differentiates into a T helper 2 response. So the transcription factor that causes differentiation to T helper 2 is called GATA3. And it's the one that now, you know, once you have a T helper 2 cell, the cytokine that it produces are majorly interleukin 4, interleukin 5, and interleukin 13. Okay. The other factors that would drive the differentiation into this phenotype of T helper cell, you know, would be the type of antigen, where it's located. For example, we've talked about the mucosa being where these allergens or antigens gain entry into the body, the type of pathogen-associated molecular pattern that will be activated on this, or that will be involved in recognition by this antigen-presenting cell, and so forth. Maybe I won't examine you on those details. Unless it's an MCQ. So don't worry too much about that because we're not really studying allergology. Okay. And the other thing to note is that the T helper 2 polarization increases over time. So, you know, there's like a positive feedback loop. You know, you're getting your T helper 2 cells secreting interleukin 4. Okay, it stimulates your B cells to secrete IgE. This IgE binds to mast cells. When the mast cells degranulate, they also contain, you know, you remember you have your preformed and your newly formed mediators. Okay, so some of these newly formed mediators include now other cytokines being produced. So you still get more of these cytokines like interleukin 4 being produced, comes back, stimulates your T helper cell. So you're getting a positive loop. So this is what leads to more and more skewing of the T helper 2 cells. Okay. Okay, back to predisposition. I've talked about your genetic and environmental influences. I've talked about the fact that the incidence of allergies is increasing globally. In the developed world, apparently up to 40% of the population are affected by some sort of allergy, which is a big population, okay? And even for us in the developing world, the prevalence is increasing. So, you know, just to support the fact that the allergies run in families and the genetic basis, it's been shown from twin studies that 80% of the risk of allergy is genetic. But we know that, you know, a genetic predisposition on its own is not enough to make someone now develop a disease. You always have, if you know the whole concept of sufficient, you know, necessary but sufficient, or what am I trying to explain? I think this is a concept should have covered in public health. The risk factors for certain diseases, you may have some that are necessary, meaning without that risk factor, you don't get the disease. You may have one that you term as sufficient. So on its own, it will cause a disease. So you can have something that is necessary, but not sufficient, which is most of the genetic factors. Okay. And then I've talked about inheritance of the atopy trait, meaning that affected family members may have different allergies. So it's the risk that is inherited, but not the specific allergy. Same thing with autoimmune disease. We know there's a genetic predisposition to autoimmune disease, but it doesn't mean that people in a family who have that genetic risk will develop the same autoimmune disease, okay? Okay, so just summarizing your predisposing factors. So you have your genetic determinants. So the genetic determinants could involve more than, different types of genes whose products are involved in the immune response. So for example, HLA, your cytokine genes, especially the ones of the T helper 2 response. So, the genes that code for interleukin 4, 5, 13, your pro-inflammatory response genes, maybe these are, they are downregulated. The genes involved in the degranulation response, the genes involved in the production of your pattern recognition receptors. Remember, I've mentioned, for example, the toll-like receptor 2 and the different types of toll-like receptors that are involved in innate immune recognition. So the TLR2 being the one that's important in driving a T helper 2 response and so forth, okay? So it's not just one gene, there's several. The environmental determinants would include things like excessive hygiene. I think I've already alluded to the hygiene hypothesis, where it's been shown that people, when children don't have exposure to pathogens in their early life, this predisposes them to developing T helper 2 responses. And I think they've actually, done sort of trials or cohort studies where they followed up children. I think these were done majorly in New Zealand, where they compare children who grew up in the farms and those who grew up in the cities. And they actually saw that the incidence of allergies is higher in those who grew up in the cities, because in the farm, they're exposed to different types of pathogens as they play in the soil, interacting with the animals and so forth. And even studies coming from South Africa have been able to show that there's a higher incidence of allergies in children who grew up in the cities as opposed to those who grew up in the rural areas. Receiving antibiotics and vaccination as an infant. I would say these, I don't want to put this forth as a strong environmental determinant because I don't want to create anti-vaxxers out of you. And remember, I mentioned that for allergic responses to vaccines, it's really, most of the time, it's not really the antigen in the vaccine that would be responsible. It could be one of the constituents. For example, back in the day, they had some of these vaccine antigens were cultured in chicken embryos. Okay, so if you had someone who was allergic to chicken, for example, and you gave them that vaccine, you administer that vaccine. Remember, they would have some of that chick embryo as a residual component of that vaccine. So that is what they would be responding to, okay? Having few siblings, I guess, maybe you're not interact, when children play and interact when they're young, they expose each other to different pathogens, from, licking each other and just the things that the young children do. So maybe that is why, the less siblings, for example, if there's only one child in a family, they're not playing with other children unless they're in school, who knows? Presence of pollutants. So as much as urbanization, urbanization has come with, more hygiene, but also with industrialization. It comes with industrialization and you have pollutants in the environment, for example, exhaust fumes. So it's been shown that this may be what is triggering the increased incidence of allergies in urban populations. Altered microbiota, so the microbiome, there's also a lot of research going into the microbiome in regards to immunological responses and predisposition to different diseases. And this, could be altered by medications, for example, antibiotics, could be altered by, different diets, and so forth. So the microbiome is a whole, it's a whole science on its own right now. Okay. And then now triggering events. So you have a patient or someone who has a genetic risk factor, has several environmental risk factors, and then now they get a third event that now would trigger development of an allergic reaction. Okay, so either flare-up of chronic illness, acute exposure to pathogens, emotional stress, hormonal fluctuation, nutritional deficits. People think vitamin D is very important here, and exposure to pollutants. So, all these combine in different ways to just influence development of allergies to particular allergens. Okay, mechanism of type 1 hypersensitivity. This is just revision. Remember, you have a sensitization and then an effector phase. So sensitization phase would be at first exposure to the allergen. So here's our allergen, gains access to our submucosa. Remember, we said it's got some proteolytic or enzymatic activity. Recognize biodendritic cells using certain pumps. Okay, let me not highlight the pathogen part of that. Remember, your dendritic cells will traffic to the nearest lymph node to go and present that antigen to a naive T helper cell. Okay, and then the nature of what toll-like receptor was involved, the type of antigen, where it was found, will influence polarization of this T helper cell. Produces interleukin-4, which will act on other T helper cells to also polarize them into a T helper 2 phenotype. Okay, and you can also have antigen presentation by if the allergen finds its way into your lymph nodes. Remember, an antigen can interact directly with a B cell on the B cell receptor, and you get recognition of that antigen. So you can have the same occurring for your allergen, which can present. Remember, for you to get your germinal center reaction, where you change your isotype of antibody produced. Without a germinal center reaction, the antibody produced will be IgM. Okay, so to get your isotype switch, you need a T helper response or T helper activation of your B cell, and that T helper cell has to be activated against the same antigen as this B cell that is trying to be activated. So here you can either have your B cell presenting antigen to a T helper 2 cell, or you can have your T helper 2 cell coming to provide help. Okay, and that help is basically in form of producing cytokines that will activate your B cell. So you have your activated B cell, and your activated now T helper 2 cell, which your B cell now will produce cytokines, IgE under influence of the cytokines produced by your T helper 2 cell. And the important cytokines we've mentioned are your interleukin-4, 5, and 13. Okay, so this will cause your B cell to preferentially produce IgE. And we talked about the fact that IgE has a very high affinity for, remember, this is occurring in blood. Okay, and IgE has a very high affinity for its Fc epsilon receptor that is found on mast cells and basophils and eosinophils. So as it's produced, it will preferentially go and coat these receptors by binding onto them. So that's the sensitization phase. So it means now, that's the first ever exposure to that allergen. So now this patient has allergen-specific IgE because they have allergen-specific B cells and allergen-specific T helper cells. So effector phase will occur on second exposure to that same allergen. Okay, and it has two phases, an early phase and a late phase. Okay, so the early phase is where you have exposure to the same allergen. Remember, your mast cells are found in the tissues. Okay, so if the allergen is coming into the body through the same mechanism where the mucosa gets, to submucosal surfaces, you have some mast cells there. So it will just go, the allergens go and bind, and here you can see the cross-linking I was talking about, where you have two IgE molecules involved in binding the same allergen. and that causes degranulation of your mast cell. It releases the contents of its granules. The preformed mediators, will have an immediate effect. So your histamine, serotonin, your chemotactic factors and proteases. And then this also induces generation of new mediators, which include cytokines, okay? And all these mediators are the ones that are responsible for the specific symptoms that we see manifesting in these patients. Let me see if there's a question on the chat. How is it that the hygiene hypothesis is still a hypothesis despite evidence of research? What are the shortcomings? So I don't really know what the shortcomings are, I guess, because probably this is observational sort of research. Like, they've just followed up these children from, so they're born, you determine where their residences are, and then they're just followed up to see, but it's not proven, to prove a hypothesis for sure, it would have to be in an experimental situation where it's the investigator that is assigning the exposure so that you remove, and you need to randomize, like what they have in clinical trials, so that you're assigning specific exposure. So for example, you're taking this child and you're deliberately exposing them, like maybe you take two children, one you're exposing to like pathogens and one you're not, and then you follow up and see the outcome. So probably that may be why, but it still called the hygiene hypothesis, or some people call it the hygiene theory, okay? It's not 100% foolproof, okay? Meaning that there are people who will be born, will have the exposures that you're thinking are predisposing them. Are reducing the skewing to T helper 2. So, they're exposed to germs, but they'll still develop allergies. Okay, so it's not 100% foolproof. Is it only mast cells that have the high affinity receptor? No, so I mentioned also basophils and eosinophils have them. Which of the cells that will have GATA3 transcription factors? So these transcription factors, I really don't want to go into details of these. It's the naive T cell. So it's basically a gene that now is going to be transcribed, and will, when the product is when that gene is activated, it will guide the differentiation of that cell. Okay. So it's the T helper cell that would have, so that will be, when a cell is activated, by a certain ligand binding to a certain receptor, you need that signal transferred to the nucleus. So you get your signal transduction. And then depending on what the ligand was, you will get, you want a certain effect by, the effect of that ligand binding. So in this case, it is this particular transcription factor that will be activated. It's a T helper cell because, for example, for your T helper 1, you get a different transcription factor being activated. So it's the ligand that bounds that activates that. I think for T helper 1, it's the T-bet factor. So it's a T helper cell that has that factor activated. Okay. Could you repeat on the antibody produced when the antigen binds directly to a naive B cell? So this is your basic immunology. Remember, your T-dependent versus T-independent responses. If you have an antigen binding directly to your B cell and the B cell being activated, the default antibody produced will be IgM. Okay, but we know that B cells can produce other isotypes like IgG, IgM, IgA. Okay, no, not IgM, IgG, IgA, IgE. So it's only if they receive T cell help, which is, a signal from T cells, which we call now the T-dependent B cell activation, that you will get isotype switching. And that is what we call that germinal center reaction. So what that germinal center reaction causes, or rather when you have your T cell helping to activate your B cell, you get isotype switch, You get affinity maturation, meaning you get antibody that binds with even higher affinity. You get somatic hypermutation. Okay, so just go back and revise your B cell activation. I'll come back to the epitopes of the allergens because this is in testing. I hope I included it in this lecture. It may be out of your scope. This one I usually emphasize for the residents in pathology and IMED and PEDS. But I'll if I remember, I'll mention it. God, I'm running out of time. Okay, so the late phase is majorly mediated by your eosinophils. Okay, remember, your eosinophils also have your Fc gamma receptor, Fc epsilon receptor. Okay, so they also have Ig on it. So the late phase is basically induced by degranulation of, when you have your cytokines being produced as your newly formed mediators, they come activate your eosinophils. You also have degranulation of your eosinophils because of allergens binding onto them. And now these now continue to produce or to release inflammatory mediators that continue causing tissue damage. Some of the cytokines produced are also like interleukin 5, causes eosinophil proliferation. Okay, so in the first phase, it's the mast cells that majorly mediate, but in the later phase, you get eosinophils being the mediators of inflammation. This is very important, especially in asthma. I think I'll send you an article that you can read that describes this a bit more, where in poorly controlled asthmatics, most of the pathology that occurs in the airways is actually mediated by inflammation from the eosinophils. Principal mediators, this is just a revision from year 2. You know what these mediators do, where they act on, and these effects are what now will cause the patients to manifest. Okay, I won't go into details of this right now. So the manifestations in the early phase response, basically what I want you to remember is that these are the ones that occur almost immediately, within a few minutes of exposure to the allergen, but they resolve within a short time, okay? So, things like your sneezing and wheezing, but they'll resolve within a short time. But you have your new mediators being produced, and it takes time to produce them. So this one's usually it's the preformed mediators that are responsible for them. The late phase response occurs a few hours later. So the symptoms come back, the ones that had resolved. Usually this occurs in the airways, and it's because of now your eosinophils migrating to the airways. So your eosinophil chemotaxis, okay, which is guided by the cytokines that are produced. And these are the ones that are responsible for chronic inflammation in the airways, okay? And the eosinophils now, they come to the airways, they release their mediators, which also cause tissue damage. And that's how you end up with the pathology that occurs in the airways. Okay, clinical manifestations of IgE-mediated allergy. So they range from, severe life-threatening conditions like systemic anaphylaxis, or even severe asthma. Sometimes you get this patient who's just wheezing and will not stop wheezing, okay? That is severe. That can actually cause death because it causes hypoxia. To localized reactions like, allergic rhinitis, where it's just respiratory, upper respiratory airways involved, or eczema, where it's the skin involved. So the nature of the clinical symptoms usually depends on the route by which the allergen enters the body. So more often than not, if it enters via the respiratory pathway, you expect respiratory symptoms, okay? But it's not a hard and fast rule. So food allergens can also cause respiratory symptoms, okay? The other thing that will guide the nature of the symptoms will include the concentration of the allergen, but it's also not a hard and fast rule. So like a low dose environmental allergen may cause, just a localized reaction. And you expect that very high doses may now cause anaphylaxis, but sometimes you can get low dose inhalation causing anaphylaxis. And actually, it's been shown, like some patients who have certain types of seafood allergies to particular types of fish, even just inhaling, like if they are in a kitchen where that type of fish is being cooked and they inhale, so it's not that, as it's being cooked, you get some particles released in there. If they inhale that, they can get anaphylaxis, okay? And then prior allergen exposure of the host. I'm sure you know what anaphylaxis is. It's a shock-like state that can be fatal, which would occur within minutes of exposure to a pathogen. Most of the time this occurs when, not to a pathogen, to an allergen. Most of the time this occurs if it's introduced directly into the bloodstream. So, like from an injection or from food allergens. Okay, so it's absorbed directly from the gut. Sometimes if it's absorbed from the skin, especially when there's a breach in the mucosa, like in a patient who has eczema. Okay. And so the mediators are the ones that are responsible for these systemic effects, the dyspnea, hypotension, and contraction of smooth muscles. In the GIT, that would cause defecation. In the GUT would cause urination and so forth. And in the airways would cause bronchiolar constriction that causes wheezing. Treatment is usually with epinephrine, which will counteract the effects of the mediators, so causing relaxation of the contracted smooth muscle or reducing the vascular permeability and improving the cardiac output because you want to correct the shock or the vascular collapse. Okay, so for the different manifestations, allergic rhinitis, usually caused by inhalation of common airborne allergens, but I mentioned that food allergens can also cause allergic rhinitis. Okay. The mechanism of inflammation is the same. As long as you remember, your type 1 hypersensitivity response, your sensitization and your effector phase, and then release of the mediators. Symptoms will include tearing from the eyes, runny nose, sneezing, and coughing, okay? For asthma, usually the inflammation would be in the lower airways. And the major thing that occurs is that you get constriction or contraction of the bronchial smooth muscle, which causes bronchoconstriction that manifests with wheezing. You also get increased mucus production, okay? So patients usually will present with coughing and wheezing. Remember I told you that you can get degranulation of muscles by other things aside from involvement of IgE. So cold or exercise can also induce what we call intrinsic asthma, okay? So not every asthma is IgE mediated, but most of the time it is. For atopic dermatitis, here the manifestation is on the skin with an erythematous skin rash, okay? Different from a delayed type hypersensitivity reaction, even the inflammatory phenotype, because here it's T helper 2 cells and not T helper 1 cells. And then the other cell type will be your eosinophils. In a delayed type hypersensitivity reaction, the other cell types will basically be your macrophages and your lymphocytes. The other manifestation are the food allergies. I mentioned that these are very frequent in children, so infants and toddlers, but the prevalence decreases as they grow. The most common allergens in children are cow milk, eggs, peanuts, tree nuts, soy, wheat, fish, and shellfish. In adults, predominantly, they're nuts, fish, and shellfish. Okay, the mechanism is the same. You get your allergens. Remember, they have protease activity. So, disrupting the epithelial barrier within the gut, getting to the submucosa, they interact with the dendritic cells, you get sensitization. Second exposure, you get your effector phase, okay? But you can also get the allergen finding its way into the bloodstream from the gut. So that is why food allergens the manifestations may not be just limited to the gastrointestinal tract, where they could be like vomiting, diarrhea, bloating. You can also get your airway manifestations with exposure to food allergens. You can also get anaphylaxis. Okay. I'm trying to finish, so I will leave you to read this. These are other hypotheses on, why do some people develop food allergies when most of us become tolerant? Okay, so just this is to do with the different environmental influences we talked about. Things like infections also, because infections will disrupt. If you have a gastrointestinal infection, that may be the environmental factor that comes in to now increase now the predisposition in someone who has a genetic risk factor. Okay. The other thing is that you can get cross-reactivity. For example, some people may have allergen-specific IgE against pollen. And then let me give a locally relevant example. And then they take honey and then they get an allergic manifestation. And it's because you may get some remnants of pollen in that honey. Okay. I've talked about other things like dietary involvement. People think vitamin D, either too much vitamin D or too little vitamin D increases the risk. It's not really known. Altered fat consumption, reduced antioxidants in the diet. The other thing that probably explains why younger children are more predisposed to food allergies is because they don't have they may have a leaky gut barrier. So it's thought that the epithelium in the GIT matures with age. So maybe the fact that the epithelium hasn't matured well is what predisposes them to having these allergens get into the submucosal surfaces. But as I mentioned, most children usually outgrow these allergies. What happens is that they just become tolerant. Okay. Okay, so now to testing. I talked about total IgE and the fact that it's not very helpful as a screening test because there are other things that may elevate IgE, and the fact that this total IgE could include IgE against, your helminths, for example, okay? Your pathogens like your aspergillosis also induces IgE immune responses. And then remember when I talked about when we discussed our primary immunodeficiencies, that those that are associated with very high IgE levels. So I would not advise total IgE as a screening test for allergy or for atopy. Okay. Allergists like the allergen-specific skin testing. Pathologists like the in vitro testing. Okay. So these are skin tests that the allergists perform. So basically, just introduce a small amount of relevant allergens. So back to the history, when you're evaluating this patient, the things you think about in the history. So yeah, they're coming to you, they have symptoms you think may be manifestations of an allergy. So you need to ask about the relevant exposures. Then those exposures are the ones that you'll come and test them against, okay? So if you have a child in the ward who you think has an allergic manifestation and they've never been near a horse, there's no point of testing them against horse dander, okay? Or they've never eaten seafood. They're from Kibera. I don't know where they'll find seafood. You would not want to test them against that. So it has to be the relevant antigen. So when it comes to evaluation of these patients and trying to come up with a diagnosis of a specific allergen that is causing triggers, the history is very important. And the allergists usually take very detailed histories, especially of the food. They would want to know, what does this patient eat every single day on the regular, in the morning, at tea time, at lunchtime, at dinner time, so that they know what are the likely exposures. Okay, so this is injected under the skin. Of course, if they're exposed, you'll expect that they'll get what we call the wheel and flare response, because you'll trigger the effect. If they're exposed, they're already sensitized. So you trigger a response, which is caused by the mediators. So your vasodilation and so forth is what would cause this sort of wheal and the redness. Usually histamine is used as a positive control. So, because one of the mediators is histamine that will be released by your mast cells. So the response is compared to the response to histamine, and then your negative control will be saline. Okay, so the in vitro test is the same. It's just that now we are using a different platform in the lab. So using, for example, ELISA and the other tests that use, for example, Western blots, and then you're detecting the binding of the specific IgE in the serum. So if it's an ELISA, for example, you have the wells coated by the different allergens. Okay, in vitro testing is preferred if a patient has skin conditions that would interfere with skin testing. So for example, if they have a rash, it would be difficult to differentiate the rash from your skin testing results. So those patients usually would be sent for in vitro testing. In infants or very young children, if maybe the patient has been on antihistamines for a long time, so usually for those going for skin testing, they have to be on antihistamines for a minimum of 2 weeks. Because, if you have any available antihistamine in circulation, it will interfere with the results. Okay, so they need to have been stopped. And then if maybe these allergens that are used, you don't have one that is safe for in vivo use, then you'd go for in vitro testing. So in vitro testing, a few pointers on this. Presence of the allergen, of the antibody, the allergen-specific antibody, does not mean the patient has allergy towards that allergen if there is no positive history. Okay? Why do I say this? Because remember I said these patients can become tolerant. Okay, so you may send someone for a panel. Why I'm mentioning this is because a lot of the in vitro tests are in form of panels. Like you have a panel of like 10 different environmental allergens, another one of food. If you send a patient for that panel, blindly, and then they come with positive results, and yet in the history, for example, this patient has never interacted or been exposed to some of these allergens. It doesn't make sense, okay? So there has to be a positive history, okay? So the fact that they have detectable allergen-specific IgE just means that they're sensitized and they may be at increased risk, and this comes in with the interpretation of these results. There may be, there's an increased risk of experiencing allergic symptoms, but it doesn't mean they have that allergy, okay? And even the amount of IgE in serum, it doesn't correlate with the severity of symptoms. Remember I mentioned that you may have a patient who has very severe allergy, but they don't have very high levels of IgE in their serum, and vice versa. You may have one who has high, maybe SIG against peanuts, but they just eat peanuts and they're fine, okay? So the levels don't correlate like that. So what I wanted to mention, I think there's a picture I wanted to place, but I didn't. But what I want to say is that right now, from the in vitro testing, people are even moving to what we call molecular allergology. So your in vitro testing, for example, would have, if you take peanut, so it has the peanut allergen. Okay, so maybe your ELISA plate is coated with the peanut allergen, and then you want to detect if the patient has specific antibody against this peanut allergen. Now, it's been shown that there are certain epitopes on this peanut, for example, that are the ones that are responsible. So not all the epitopes are responsible for this type of allergic responses. So in molecular allergology, they actually now test for specific IgE against the specific epitopes. Okay, I think that's what I wanted to mention. For example, you have peanut, and then it has an epitope called ARA-H1, another one called ARA-H3. So they test for those specific antibody against those specific epitopes. So that's molecular allergology. Okay, the other test that can be useful is the mast cell tryptase. This one ideally would be used if you suspect that a patient, maybe a patient comes in with what you think is an anaphylactic reaction, and you want to confirm that because it tells you there's been in vivo mast cell activation. Okay, So it just measures the amount of this tryptase in the serum of the patient. Remember, you can get anaphylaxis that is not mediated by IgE. So this will help guide you first to confirm, is this anaphylaxis? And after that, it can guide you to know what other tests you should do after that. In terms of treatment, this one I'll just summarize. One thing I forgot to mention. When it comes to diagnosis of allergy, what the allergologists or allergists do, once they do the skin test and they confirm a positive, for example, let's see, this patient, like cat dander would be positive. It's even, the wheel is larger than the histamine wheel. So they do what we call elimination. So best done with food, actually. So if this was a certain food like peanut, you eliminate this from the patient's diet for about 6 weeks, so they're not exposed to it at all. And then you reintroduce it in small quantities, and then they document whether they develop any symptoms. So if it's reintroduced, so they keep increasing the quantity up to like what a normal like peanut snack amount would be. If it does not produce any symptoms, then it means that patient is tolerant. That means, they can eat peanuts. If they do get symptoms, then you can now say that they are actually allergic to peanuts, okay? So testing is not just about seeing, oh, this is positive, and then telling the patient, okay, you can never eat this for the rest of your life. Okay, when it comes to treatment, there's specific pharmacotherapy, there's allergen avoidance, and then there's immunotherapy. So specific pharmacotherapy would be, for example, treating the symptoms, like giving your antihistamines or your leukotriene inhibitors. Allergen avoidance is, when you can't, you tell this patient, okay, you need to avoid this because this is what is causing your symptoms. Pediatricians do not like this because, especially for children you think may be having food allergies, if you end up not doing your elimination and challenge, and you're telling them to avoid all these types of foods, most of these foods are proteins, you might end up having a child developing malnutrition, okay? So the best thing to do is just send this patient to an allergist. But for you to know, to institute allergen avoidance or immunotherapy, you need to know the specific allergen that is responsible, and that is where the testing comes in. Immunotherapy majorly involves either desensitization or blocking some of the mediators. So desensitization would be where you're trying to induce tolerance. So it involves, graded administration of the identified allergen in small quantities until the patient becomes tolerant. So remember the factors that influence tolerance, go back and revise that, okay? So the goal is to achieve a reduction in the allergic response, either saturate your receptors until there's no more response, or deplete your antibodies, or form blocking antibodies. Sometimes with desensitization, you want to form IgG that will come and block the effect of the allergen-specific IgE. The other immunotherapeutic approach I mentioned would be by blocking your antibodies. So the antibody blocking would be where they use a monoclonal antibody against IgE. So it binds to that's omalizumab, it binds to the FC region of IgE, so that will block the IgE from binding to the FC epsilon receptor. This is usually used, I've seen it being used in severe IgE-induced asthma that doesn't respond to your usual asthma treatment. Okay. I will stop there. I went over time because I'm not going to be available next week. So is it possible for a patient, okay, let me just go up. What's the role of exercise and cold water baths in relieving allergic symptoms? There's no role, not that I know of. Okay, and remember I mentioned that although This is out of our scope. Exercise and cold water can cause symptoms similar to allergy, which is urticaria. But I really don't want to go into details of urticaria. It's another very wide field. So there's really no role in relieving symptoms. Is it possible for a patient who has developed a food allergy in adulthood to develop tolerance to eat once again? So they can, but I think it's tolerance has not been shown to develop in adulthood as much as it does in children naturally. So unless you induce it through desensitization. Okay. How will the immune system be downplayed? So, as I mentioned, it's desensitization, where you're just, giving increasing doses of the allergen. Remember the factors that influence tolerance. One is the dose of the antigen. So too much would end up creating, for example, allergy, and here you're creating peripheral tolerance. Okay, so just go back and revise your lecture on tolerance, and then this will make sense. Of course, I will not examine you on, the nitty-gritty details, but it's good just to have the broad understanding. Precautions taken when performing skin tests. They have to be performed by a qualified, usually a qualified allergist. There has to be, in a clinical setting, where there's access to resuscitation equipment and medication. You have to have your epinephrine there, you have to have your oxygen and so forth, because as you're performing the tests, remember, there's always a risk of triggering anaphylaxis. So those are the precautions. There has to be someone else available to help, preferably like a nursing practitioner, in case you may need to resuscitate that patient. Okay. Any questions before I sign off? So I'll send the slides. I'll also send you an article so that you can read more about the late phase response. Dr. Walong might want to examine you on that in the context of asthma. I don't know. Okay. All right, so I'm going to sign off now.